first. Okay, can everyone see the slides?
Yes, we can.
Okay, wonderful. All right, well, nice to meet everybody. This is exciting. I've never been in like a kind of a international Zoom like this, and certainly not giving a so um my name is Wes. Like Dr. Sura mentioned, I'm one of the PGY2s here at UPMC. I'm gonna talk about bedside evaluations for the dizzy patient. I will put out a disclaimer that a lot of this is probably very elementary for especially the fellows and but I think for me starting out I wanted to really understand kind of these evaluations and the physiology behind them, so I hope I can, hope it could be a good review. So let's begin with a case. How about so, 35-year-old female presents to the ED with 1-day history of decreased hearing and uh, dizziness. So, what do you guys want to know?
So I'm gonna,
Who's
how
put?
about Aggie? Aggie, what do you think about that? Any thoughts?
So first of all, she's presenting to the ED. You want to make sure that other than the dizziness, what is everything outlook like? What are her vitals? What's her GCS? And initially, you would want to clear out any kind of life-threatening um, things associated with an acute episode of dizziness.
Mhm,
So you want to know her vitals, her GCS, ABCDs, in the emergency department. And then
mhm,
once all of that is cleared and she's stable, then you can look further into her decreased hearing and dizziness. So
yeah.
you'd want to know what she actually described the dizziness as without using the word dizzy. Is the room
Mhm,
spinning? Is she spinning? Does she have true vertigo or not?
mhm.
And then you
Very
would
good.
also want to do a full ENT exam, including cranial nerve exam, um, and just to see if there's any cranial nerve fallout. And then you'd want to perform a HENS test, or HENS
Mhm.
plus test to ensure that this is to see whether it's a peripheral or central cause of vertigo.
Yeah, that's really perfect. You got everything. So let's say she's completely stable. Vital signs are, no hypertension, like stable, everything is stable essentially. And then you had mentioned so like a full physical exam, let's say all cranial nerves are intact. And the history, like you mentioned, what is dizziness? Let's say she's just feeling imbalanced, like she's gonna fall over, walking around, doesn't, doesn't feel stable. So
Okay.
and then yeah, you had mentioned other aspects. What else did you want to know?
So you'd want to know if she's had any episodes like this before. Is this the first episode of dizzy
First,
spell
let's say
now?
it's the first one,
Okay,
and
and
she
then
has. Mhm.
and then you want to make sure her background history. Does she have any medical illnesses, comorbidities?
Yeah,
Does she
let's.
have any anemia or hypotension issues?
Yeah, she's completely healthy, no previous history, and this is the first time this has happened. And she's reporting, oh, she woke up, I just decreased hearing, oral fullness, and tinnitus.
Okay, and when you look in the ear, what do you see?
Normal ear, only normal ear, and TM intact. Yeah,
Okay,
no
and
fluid on the inside.
okay, and then does she have nystagmus?
Oh, she does not have nystagmus.
Okay, so you've performed the HINS exam. Are there any positive signs from the HINS exam?
Nope. So the There's no nystagmus. There's no corrective saccade. So and there's there's no skew, no positive skew, vertical skew.
So, and then she's got hearing, and does she have a preceding history of a viral infection or upper respiratory tract infection?
Yeah, she just doesn't know. I mean, she lives at home with her son, young son, but doesn't have any recent viral infections. So just woke up and had this like decreased hearing. And then I assume like you want to do some hearing exams. So the tuning fork, Weber lateralizes to the right side. Renee is positive bilaterally. So air conductive greater than bone conduction.
Okay, but it lateralizes to the right.
Mhm.
Okay, so then you could be thinking if her symptoms are all in the left ear, you could be thinking of a sensory neural hearing loss.
Yep. So you got it. So there's the imbalance. She's veering to one side, and so I guess it's this is exactly right. You got it. Like the first thing you want to do is get a good history, and this goes into what is dizziness. And this is just again like a good overview. There's four main categories that you can kind of break it down to give you some more to make it more discrete here concrete here. So the first is lightheadedness, like you asked, hypotension, and anemia, those things. So pre-syncope, you got to ask patients to kind of get that, um, see if they fall into that bucket. There's also disequilibrium, which is a distinct subset. So this is more her issue, imbalance, unsteadiness with walking. Patients can have oscillopsia, so just like vision shaking, and that could happen with acquired nystagmus, changes to the VOR, and this only occurs when eyes open. And of course, vertigo is going to occur both when your eyes are open and when your eyes are closed. And so there's different types of vertigo. There's rotational vertigo, linear displacement, tilt, and sometimes vertigo can be exacerbated by head movement. But again, you got it completely right. It's all about like the history first. And so that was just what I want to start with. So, that's how you can distinguish between what is vertigo which is like something else, like a imbalance issue. And so just to jump into this a little more, so the balance portion of things, there's three primary systems for balance. They are going to be the vestibular system, vision, and proprioception. And beyond the primary systems for balance, there's secondary inputs here. So the auditory system, you are always using auditory cues to localize objects and orient yourself in space. And this is important when vision is impaired or you're in darkness. So, and then this is essentially why the patient is experiencing balance issues is there's a sudden loss in one side of hearing. And so there's an uncompensated secondary system here for balance. Cognitive systems is why we see patients who are older with decreased cognitive reserve. They have more issues with balance because you need that attention and executive function. The motor system, of course, this is important. You and also why patients who are older and more frail have issues with balance. And then the autonomic system, like you mentioned, blood pressure regulation, those positional changes in blood pressure, that's all of these systems kind of coalesce into balance. So the test you would want to do in a patient who is experiencing some imbalance, Romberg test is the famous one. It's just a little history here. Historically, it was used for tertiary syphilis, patients who had tabes dorsalis, which is the lesion along the dorsal column of the spinal cord. And so this removes the visual and the vestibular component so you can isolate just the proprioceptive component. So this is positive. If you're able to stand on the feet, place together, your eyes open, but then when patient closes their eyes, they paradoxically sway or fall when their eyes are closed. And some causes of this, uncompensated unilateral or bilateral vestibular dysfunction or loss of proprioception, and the pathology is in a cerebellum. And it is pretty specific for dorsal column disease. The sensitivity and specificity is lower for vestibulopathy. So certainly this is not a test that's going to nail down like a peripheral vestibulopathy, which is something that we're probably more interested in. So just again, very simple review, how to do it. You ask patients to put their feet together, arms next to the body. They keep their eyes open. You see how they balance, and then you have them close their eyes, and you look for loss of balance. If they're swaying, that means their proprioception is still intact, and they're able to compensate for the movements in their body. So another test of balance is going to be the Fukuda step test. This was this was created by Dr. Unterberger and Fukuda. They observed this body rotation in patients with vestibular disorders, and so you have patients kind of march in place essentially, and if there's a rotation that's greater than 45 degrees in any direction, that could signify vestibular dysfunction. There's also lateral deviation, and the numbers here are kind of what the numbers that they've set up. So 45 degrees, and then lateral deviation of greater than 2 meters. This is possible vestibular imbalance. And then if there's a forward progression greater than 2 meters, possible vestibular or proprioceptive deficit. And then some causes of this are uncompensated unilateral, bilateral vestibular dysfunction. And so the sensitivity and specificity of this have been reported also similar to Romberg, pretty low for vestibulopathy. But there is some studies showing that while it's a poor predictor, it may be valuable for the prognosis of BPPV. And how it's done, you have the patient put their feet together, arms outstretched, and have them march in place. And then again, you observe for change in the rotation, lateral deviation, or forward march. So those are the main balance tests, bedside evaluations that you want to do. So let's move on to case 2.
Can I add something to that?
Oh, yes, of course.
Just a quick thing. I don't know if you do use this at all, Greg, but I find that it's sometimes helpful to have the patient stand with their arms out, not actually stepping in the Fukuda step test, just keep their arms out. And I move their arms in different directions with their eyes closed. And I see how that perturbs their balance. I find that some people exaggerate their dizziness. And if I move their arms around and they maintain their balance better than when I'm not moving their arms, than when they're just standing still and they're swaying all over, it helps me to sometimes ferret out a little bit of exaggeration in their physical examination where they may be somewhat fainting. I heard somebody once say that of the dizzy patients, 25% will be telling you exactly the truth, exactly as it is. 50% are exaggerated and 25% are outright lying. I don't know if that's true or not, but I think there's something to be said for trying to help distinguish a little bit between those patients who are giving you their very best effort and those who are maybe a little bit feigning some of the symptoms that they're having.
Yeah, that's interesting, Brad. Oh yeah, I haven't done that now. Actually, I just have them stand in more of a static sort of position, but I think that's really interesting because
Yeah, put their
it's
arms
kind
out
of
now,
hard
move
to,
their arms.
yeah, it's kind of hard
Yeah,
to, it's hard to fake that, right? If they compensate well for that. And yeah, that's interesting. Yeah, interesting.
yeah.
Yeah.
Sorry to interrupt you. Keep
No,
going.
I think that's a
No, no.
really important point. That's an interesting, yeah, that's why this
Yeah,
is
and
fascinating. You get nuance of some of these tests, and I think that's like the equivalent that's the bedside vestibular equivalent of like a Stenger's test in a way for
Yeah,
audiology.
yeah.
Yeah, that's great.
and yeah, feel free to interrupt whenever. This is obviously a discussion and kind of open. So yeah, please. All right, so case 2, let's say, so 56-year-old male complains of positional vertigo, began 6 weeks ago. So what are some things you want to know here?
Well, like, okay, Nina's gonna do this one.
Would still go through the
the initial assessment, and it's important if they said they've had vertigo 6 weeks, what do they mean? Are they dizzy every day? What triggers the dizziness? Is it positions coming from supine to standing, sitting to standing? Is it turning in bed? And when they get the episodes, what is the exact duration? Sometimes patient can't tell you the exact duration, but they'll estimate, is it just a few seconds? Does it take minutes to hours? Is it entire days of feeling unwell? And then what are the associated symptoms that they have? Which you answered
Yeah.
it.
Yeah, perfect. Yeah. So let's say the symptoms occur when they feel like they roll over to the right, and then when they reach above its head, and obviously otherwise stable, and then they say it's coming on. It's lasting for like seconds to minutes, and there's no
Any
other
associated,
neurological.
no other associated symptoms. So just any hearing loss, oral fullness, or tinnitus. No,
Nope,
so
no
sounds.
neurological symptoms.
So from what we know so far, this is most likely BPPV,
Hmm.
and
Exactly.
yeah.
So.
So part of your physical exam for any busy patient, you still do your full cranial nerve exam. But to diagnose BPPV, especially for the posterior canal, we do a Dix-Hallpike maneuver.
Perfect. Yeah. So all of the other exam is normal, and then you have Dix-Hallpike, which is positive with the right ear down. So question here is which direction was the nystagmus? Kind of a bonus here. Actually, let me just, for sake of time. So it is upbeating, it's towards the forehead, and it's torsional. So the and upper poles you see of the eyes beating towards the right ear. So like you mentioned, it's BPPV, and the bonus here is that it is the right ear that's going to be the issue because the eyes are torsional beating towards it. And so just talking about the Dix-Hallpike test here, this is obviously like a review for most people, but you're looking for positional nystagmus. So BBPV, it's theorized to be otolithic debris, and they detach from the macula and they enter into SEC, the superior semicircular canal, and the pattern of the nystagmus depends on which superior semicircular canal is involved. And then for the most part, large majority of patients have a posterior superior semicircular canal, BPPV. And so that's why what you'll see in Dix-Hallpike test is a upbeat mixed and upbeat. Sure, that this is it. So it's a nystagmus that is mixed. It's upbeating and it's torsional, and the rotary component of it is going to rotate towards the affected ear. And so this is just an example of what you would do with a Dix-Hallpike test. You would have patients sit up, they would turn their head, and then you would slowly would drop them down. And so there are some patients who have a stiff neck. And so an alternative to this is you can do a side lying test. So you can have them kind of do the same thing. You look to a certain side and then just have them hold it there and then slowly bring them down, but you don't have to bring them down past the glass being flat. And you would look for nystagmus after that. And so with BPPV, I'm sorry, another one is, so that's for posterior semicircular canal BPPV, but there's also the supine roll, which looks for BPPV of lateral semicircular canal. And so you have patients kind of slide down, and then they turn their head kind of side to side here. And then this is just showing an example of what would happen with the otoliths in the lateral semicircular canal that would then initiate the nystagmus. And of course, we all know that BPPV can be treated with certain maneuvers. And so the Epley maneuver, modified Epley maneuver, is one that's good for posterior semicircular canal BPPV. So you have a patient kind of sit up, they turn their head 90 degrees towards the unaffected ear, and then they continue turning in another 90 degrees in the same direction, and then the patient is moved to sitting position. And then you want to maintain each of these positions for at least 1 to 2 minutes, or until the nystagmus and the vertigo is resolved. And then other treatments include the CMOT maneuver, Barque maneuver, and Brandt Daroff exercises for patients with BPV. So so that's essentially the
One of the
yeah. Mm.
one other quick comment. Just in terms of the direction of the nystagmus, when they're let's say that they're in the right ear down position, if you have them direct their eyes towards the floor, it accentuates the rotatory component more. Sometimes the vertical portion of it's a little difficult to distinguish what's going on, but if they have their right ear down and you have them look toward the floor, it accentuates the rotatory component, so you can tell better to make sure that it's going in the right or the presumed correct direction. I don't know. Do you use that, Greg?
Yeah, yeah, exactly. And I kind of have them look in that direction. And people will describe this as geotropic, means toward the earth, or apogeotropic, which is away from earth. That becomes particularly important with diagnosing horizontal canal BPPV, which is a lot of nuance to that. Typically, yeah, so there's a lot of nuance on how you diagnose lateral canal BPPV in the roll test. But yeah, so it's like, I'll describe it as a torsional, upbeating, geotropic rotary nystagmus, right? And that's a great point, Bragg. Absolutely. It's so a quick question for the team, whoever wants to answer this, is what if you lay the patient down in a Dix-Hallpike position and they immediately have nystagmus and it doesn't extinguish in that position? What does that make you concerned about? So normally the typical response is you lay someone down in the Dix-Hallpike position. They lay there for a second, and then you can almost hear them. They say, "Oh no! Oh, here it comes! Oh, here it comes!" And then all of a sudden, you see the nystagmus, the expected nystagmus, and then it typically extinguishes if you hold them in that position long enough. What if it doesn't? What if it's on? What if it comes on immediately and it doesn't extinguish?
Would you
Is
then be
is it still BPPV?
would you not then be more suspicious for like a central cause of
No,
Yeah.
but most probably it could be cupulolithiasis. You could have the otoconia stuck onto the cupula, so that immediately you go in the position, the dependent position, the deflection of the cupula is immediate, so you don't have a latency of a few seconds that you usually have when the otoconia is within the canal.
That's right. So Amin is exactly right. So what you're trying to differentiate there is canal lithiasis variant versus cupulolithiasis variant. It's a really important. The cupulo variant is very rare, but I've seen it many times. The problem with the cupulo variant is it doesn't technically or typically respond to Epley particle repositioning. So if it's persistent, sometimes it becomes a surgical problem. We actually have to go and plug the posterior canal sometimes, and even that can be with refractory canal lithiasis. You may have to have a surgical, intervention. but it's a challenging problem because it's hard to reposition that if it's a cupulo variant. So it's really important to differentiate those two clinically.
I have a question. When you have a patient and the history fits with BPPV, you've done the Dix-Hallpike and done the Epley, what's your follow-up from your practice after? When do you see them again, and what instructions do you give? And is there any role for any medication? We know traditionally maybe old practices, they used to give antiemetics, but we know those don't really do much. Some people used to give mild sedatives to help the patient sleep through the night better. I would like to know what's your practice after you've done the Epley and you're happy with the result for the patient, they're feeling better. what's the plan after that? When do you see them and what else do you give them?
Yeah, so no role for meds really. I tell them if it comes back, which there's a high likelihood it'll come back. People will quote like 5% annually that's going to recur. I do direct them to some online videos that exist. And my former institution, the vestibular therapist made some really great videos. I tell them to be very clear about which head position evokes it, because the big issue is sometimes people can have a different canal than they think is involved. And then they just start flopping around at home doing kind of random things. Well, the problem with that is you can convert, say, a posterior canal into a horizontal canal, or the worst case scenario is you get multiple canal BPPV, which is a disaster because then you have to try to address one at a time. So I tell them to keep tabs on the symptoms. If it recurs, to call. And if for some reason I can't reposition it, I'll get them to vestibular therapy because they'll have a much better, opportunity to really spend time and reposition the crystals. But it's really about being specific about the evoking position, and then educating with some videos so they can see, and then see if they can reposition on their own. If they can't, I have them call. So I don't arrange a specific follow-up. I just have them communicate with us about updates, and then I kind of triage it accordingly based on that. Brad, I think you had a comment.
I did. I had one other comment. You had asked, when they're in the Hallpike position,
Mhm.
if they get immediate onset and it doesn't resolve. And I think of those as potentially being vascular compromise. Maybe you said that and I just missed it, but I worry that maybe they've got a vertebral occlusion or something. And so as long as they're in the offending position, they continue to have vertigo. That's not
Mhm.
typical for BPPV of any sort. I think the one thing in my mind that distinguishes between cupulolithiasis and canal is that when you do the Epley maneuver and you roll them over completely, when they sit upright, their nystagmus should continue in the same direction that it was going before. If it reverses, if the rotatory component reverses, then it may be that the otoconia are stuck on the cupula, and therefore, when they come up, it starts going the other direction. But if it's true classic BPPV, where it's due to canal lithiasis, where the otoconia are floating freely in the canal, then as you do you do the 360-degree kind of rotation with the Epley maneuver, the direction of the rotatory nystagmus should continue in the same direction that it was when you started the maneuver.
Do you see classic rotary upbeating torsional nystagmus? I don't normally see that with like a vertebral artery issue though so much. When I see the rotary upbeating that's persistent, that's when I start thinking more that's like that doesn't extinguish. Yeah, that's usually kind of when I look at it from a cupulo variant, but yeah.
Yeah, I think that I think that extinguishes. It's just it
Yeah.
just changes direction because it's not
Yeah.
completely subject to gravity. If it's still stuck on the cupula and you tip them back up, then it goes the other direction and the
Yeah.
rotatory
Yeah, in
nystagmus
the
reverses.
position, like Hallpike position, I've seen a couple of these cases where it just keeps going.
Huh.
Yeah, I haven't seen it really extinguish. It's really fascinating.
Better check their vertebrals.
Yeah, yeah. Interesting. Yeah.
Okay. So just kind of transitioning back here, the with Dick's Holocaust, we're looking for nystagmus. So for me, just to try to understand and demystify a little bit, is like what is nystagmus? So it's derived from the Greek nystagmos. It means nodding, drowsiness. Like when you're tired, you're nodding down, your head kind of pops back up. So it's rhythmic, it's involuntary, and it's rapid oscillation of the eyes. So there's two stages of nystagmus. There's a slow phase and then a corrective fast phase. And just really for me, a terminology review, because I don't want to confuse these things, is there's fast phase, which is a rapid involuntary correction, but there's also saccades, which is purposeful and conjugate. So we're Yeah, so that relies on actual moving our own eyes. And so that would be a saccade towards a point of fixation. And then there's slow phase, which is again an involuntary drift of the eyes, and smooth pursuit, which is voluntary, and it's used to keep the target on the fovea. And so you can't really talk about nystagmus without talking about physiology here and the vestibulo-ocular reflex. And so this is a reflex that generates eye movements, and it compensates for head movements. And it's a very fast reflex and bypasses or doesn't require the cerebellum for this. It's just, and the difference here is that compared to a visually stimulated eye movements, like I mentioned, the kind of purposeful movements, those are longer latency. And the classic thing here is that chickens, they keep their head very still as you move them, and because they can't really move their eyes, and so they've developed kind of a vestibular ocular reflex here that you can actually see in real time with their head. And then the physiology here is that, with the three semicircular canals, these are the ones that they sense angular velocity. So they are responsible for the angular component of the vestibular ocular reflex, whereas the two otolithic organs, the utriculosaccule, these sense translational and accelerational. So they're responsible for the translational aspect of the vestibular ocular reflex. And just a little more detail here with the canals. So like Amina mentioned before, we're talking about the cupula and kind of the hair cell function within them. So if you look at the ampulla here, you see that so ampulla is a swelling that joins the canal with the vestibule. And the crista is the structure in the middle here that has hair cells that then extend their cilia into the cupula, which is the central portion here, and essentially blocks the flow of endolymph coming in. And so whenever there's a flow in here, actually this slide here, so this hair cells are oriented in the same direction. And whenever there's an endolymphatic acceleration, it pushes the cupula, and the cupula then moves all the hair cells in a certain direction, and this causes the signals that then initiate the VOR and the VOR response. And so physiologically, we've evolved a response where it's constantly firing in both ears, and the motion of the head would just change the rate of firing. And so it would change the rate such that when you turn ahead a certain side, that ear would fire at a higher rate than the contralateral ear. And this allows for a quick transmission of information. And so like mentioned here, if the head turns to the left, then the left side sends increased signals, and your brain senses that as your head is moving towards the left. And so the vestibulocular response then drives the motion towards the right of your eyes. And so there's ways to increase the firing rate, and we touched upon this, but calorics, so with warm water or cold water, there's whole body rotations, and then there's head rotations similar to the head impulse test. And important distinction, especially for me when I'm doing physical exams, is physiological nystagmus versus pathologic. So physiologic end gaze nystagmus is when I make the patient kind of turn follow my finger, and their eyes goes too much to one side, and the mechanical forces then kind of stop you because you're at an extreme end of gaze, and so the mechanical forces pull you back, and their eyes still want to continue that direction towards my finger, and so that is seen as a nystagmus, but it's a physiological, and it stops when you bring them back to neutral gaze, versus a pathologic nystagmus, which would then continue. And there's other types of physiological nystagmus too, like when you spin a patient, you do caloric testing and optokinetics. So when they're kind of looking at some visual stimulation that is a little more chaotic and that could induce nystagmus. So that's as opposed to spontaneous nystagmus, which is pathologic, and there are different types. And I don't want to go through the entire list here, but there are some localizing types, and these can bring you. This is more of a neurology thing, but it can kind of tell you where along the brainstem or cerebellum it could be occurring here, the lesions. The important one that we should know is the Brunn's nystagmus, which is gaze evoked in one direction, and it is small amplitude, high frequency, and it's gaze paretic in the other direction. And so you can see this patient here who has increased high frequency, small amplitude when they're looking to the left, and then when they're looking to the right, it's a large amplitude and it's slower frequency. And this is portends. This occurs when there's CPA tumors, especially vestibular schwannomas, and it's on the gaze paretic side. So in this case, the right side here. And then you can't really talk about this without talking about Alexander's law. So this is the idea that your nystagmus would increase if you have the patient look towards the direction of the nystagmus, and then decrease if they're looking at the opposite direction. And related to this is the degrees of nystagmus, and this helps us to determine the severity of the lesion. And so a first degree nystagmus is it's only present when you have a patient looking towards the direction of the fast phase. You can see it. It's usually suggests a unilateral peripheral lesion. Second degree is when they're just a primary gaze. You see the nystagmus in that direction as well. And so that indicates a more moderate dysfunction. And a third degree is when you have nystagmus that is present with all direction of gaze. And that could suggest an acute peripheral lesion here or a central compensation failure. And just a note here, especially relevant for us, when you have patients fixate on a finger, this can suppress the nystagmus and therefore make it more difficult to see. So it's better to ask patients to look left and look right. And then so just to kind of synthesize that, if a patient has a right vestibular right vestibular neuritis, which direction is the nystagmus and why? Any volunteers here?
So I think it depends initially on the stage of when the vestibular neuritis is. If it's in the acute phase and like the irritative phase, I think that the nystagmus is towards the site of lesion, but then later on it goes towards the opposite side of lesion, I think.
Yeah, so this is, I guess you can say this is more of a later phase, or this is the phase that you would see them present. And so vestibular neuritis, so the right side is a decreased firing on that side. And so, yeah, you're right. So it's going to be, the nystagmus is going to be on the left because decreased firing on the right side is equivalent to turning your head to the left. And so the vestibular response then reflexins moves to the right, which means the fast phase moves to the left here in the nystagmus. So awesome. And so there's just briefly, there's ways to induce or modulate nystagmus. And so there's gaze evoked nystagmus here. And this is specifically the nystagmus that occurs with the direction of gaze. And if they're beating in all directions of gaze, then you're thinking of central, you're thinking of cerebellar dysfunction. If they're purely vertical, midbrain, and purely horizontal, this is localizing more to the pontomedullary region. And then there's head shaking nystagmus, which is similar to the head impulse test. And so nystagmus in this case beats towards the healthy ear when you have a peripheral vestibulopathy. And then so more nuanced here and less bedside and more with V-hit testing. You can see hyperventilation induced nystagmus. You have patients hyperventilate, and when they stop, you can actually see an induced nystagmus, and this has to be in the dark too. And it usually beats to the side of the lesion. All right, so moving on here, we have case 3, a 58-year-old female presents to the ED with acute onset vertigo beginning 2 days ago. So again, what would you like to know here?
So similar to the first case, so you have to, do your ABCs, ensure the patient's stable.
Yeah, patient's stable.
And then you'd want to know chronic comorbidities, if she's hypertensive, what are her vitals like, does she have a raised blood pressure, any other symptoms you'd want to exclude, or kind of figure out are sure, like headaches, and then also you need to make sure she's got no diplopia, dysarthria, or any kind of central signs which would lead you towards more of the central cause of this acute vertigo. And then you'd want to again perform a full ENT exam, including your cranial nerves, as well as a head spot plus exam to just try and assess whether or not this is a central versus peripheral cause of vertigo.
Yep, that's perfect. So
For the ENT exam, obviously again include your Weber and rhinitis.
Yeah, you hit on all the points. So we want to distinguish whether this is central and or peripheral. And if a patient here, has history of some vascular pathologies. So she has smoking history, so she has high risk. There's headaches. There's no overt central symptoms like you mentioned, like dysphagia, diplopia, but she does mention ataxia. And so you do the physical exam, you see that there is spontaneous nystagmus, it's right beating on rightward gaze and left beating on leftward gaze. Otherwise, cranial nerves are normal, sensations normal, tuning fork, so there's no hearing changes here. You do a Romberg test, which you find is positive, and then the Fukuda is negative. And like you mentioned, hints. So in this case, you do a head impulse. There's no saccade, no corrective saccades. You can see that this nystagmus is gaze evoked because it's going right with right gaze, left with left gaze. And then we do a test of skew, and you see vertical deviation. And so the diagnosis here would be a central disease, possibly a cerebellar, like a small cerebellar stroke so that you would then further test for. So that's so that's a central cause, and kind of this is in the interest of time, I'll just go through this. So 25-year-old female presents to the ED, acute onset vertigo beginning 2 days ago. So similar history on the onset. She's stable, but associated symptoms, nausea, vomiting, there's disequilibrium, there's gait instability, no oral symptoms, and no changes in strength or sensation. And you ask her like about associated history, and there's a flu-like illness that she had 2 weeks prior. And so in her physical exam, there's left being horizontal torsional nystagmus on leftward gaze. You see upper poles of the eyes beat to the left. And you're seeing this in all 3 gazes. So what is the degree of nystagmus here? And since it's left, neutral, and right, the degree here would be third, which is consistent with an acute peripheral vesticulopathy. So, and then otherwise it's normal cranial nerves and tuning fork exam, and then you do the hints. So at impulse testing, you see there's a catch-up saccade with rightward thrust. Romberg and Fukuda are negative, and then the diagnosis here would be the vestibular neuritis and on the right side. So this goes on to brings us to acute vestibular syndrome, and this is an important thing to distinguish between something like a BPPV. So acute vestibular syndrome is a patient that is coming in acute dizziness and persistent for at least 1 day. So this is accompanied by nausea, vomiting. They have unsteady gait, and then they have nystagmus that you can kind of see and elicit. And then, of course, there's it's important to distinguish that there's an absence of focal neurologic signs like hemiparesis, hemisensory loss, gaze palsy. And so, like we mentioned hints before, it allows us to distinguish between a central and peripheral cause of their vertigo. So head impulse would give you no corrective saccade in a central lesion, whereas you would see that in a peripheral lesion. And then nystagmus here, central, you would see spontaneous, you see vertigo, torsional, gaze evoked, bidirectional, whereas with the peripheral lesion, you'd see unidirectional, and it's horizontal, and you could plus or minus suppress it with fixation. And then the test of skew here, you would see a vertical saccade with a central lesion and then no skew deviation with peripheral. And so you would only do the hints exam on a patient who is coming in with constant dizziness, not just a history and then a resolved dizziness. So and a patient who doesn't have these central symptoms. And the central symptoms, like you had mentioned, Agi, there's new headache, focal weakness, diplopia, dysarthria, all the Ds, dysmetria, dysphonia, dysphagia, and an inability to walk unaided. So when would you perform Hintz and Dix-Hallpike maneuver? Does anyone know? When would you perform it on the same patient, I should say?
No, ideally, if you've taken your good history, you shouldn't be performing a Dix-Hallpike and a Hints exam with the same patient. So in a patient that has nystagmus at rest, they have constant dizziness, sometimes lasting minutes to hours or even days in your Hints exam. In a patient that comes with positional vertigo, worsened by particular positions, lasting minutes to seconds, and there are no other possible central causes to do that Dix-Hallpike. So there shouldn't be an instance where you're doing both in the same patient.
Yeah, exactly right. And it was kind of a trick question, more for me than anything else, because to help me distinguish here, you're exactly right. Hence, you only perform it on a patient with acute vestibular syndrome, whereas Dix-Hallpike, you would do it with the patient who has this positional and on and off vertigo. And so with the Hints exam, it's thought that you would need at least a 50% decrease in the inner ear to be positive for peripheral vestibulopathy. And it's a pretty good bedside exam. So there's 97% sensitivity and 95% specificity to identify a central versus a peripheral cause of vertigo. And yeah, just to briefly go over the head impulse test, we have a patient kind of look neutrally, and then you kind of move their head abruptly to a certain direction, and you would see that they would have a delayed VOR, and so then they would have a corrective saccade to then gain back the fixation of their gaze here. And this would only happen when you have a peripheral vestibular dysfunction. And so just a fun little thing here. If you see this exam, is it central or peripheral?
You play it again.
Yeah. Not this one. It starts all later. This one here.
Yeah. I thought I saw a saccade I could be wrong. I thought I saw Katlak Sakad.
You are correct. If you look closely, turning to
Yes,
the right, there is a corrective saccade. So this would be a
peripheral.
peripheral cause, exactly. Awesome. And then here, so the nystagmus portion, would you call this essential or peripheral? Perfect. Yeah. So it's it's unidirectional. It's always beating to the left. And in this case, it follows Alexander's law. You can see that when he looked to the left, there was an increase in frequency of it. And then when he looked to the right, this decrease. And it's a third degree. So you're exactly right. So it's peripheral. What about this?
Essential.
Essential. Perfect. Yeah. You see the patient looking on the left gaze, they have left nystagmus, and then right is the right. Awesome. And then this is the last one. It's pretty easy here.
Central.
Yeah, perfect. So there is a positive test of skew here. There is a deviation. So just to summarize, really, you want to rule out central versus peripheral cause. You want to see if it's you don't want to miss a stroke, obviously, and you want to see if it's vestibular neuritis. And the history is important. Vestibular neuritis occurs hours to days, stroke, seconds to minutes, possible multiple episodes of similar symptoms in the last 6 months. And then associated symptoms, you want to look for headache, neck pain, and then, like mentioned, diplopia, central symptoms here, and then look for risk factors. So in summary here, we talked about the different tests that we do. And so the first thing is a good history, defining what the patient means by dizziness. Then you can go into some balance tests, the Romberg, Fukada step test. I didn't mention the tandem walking test, but that's kind of similar. It uses your vestibular function, so similar to the Romberg. And then you will look for nystagmus, want to look for whether it's spontaneous, look for gaze evoked, and then a head impulse test. You do Dix-Hallpike maneuver on patients with the consistent history of BBV, and then Hintz examination to distinguish peripheral versus central. And yeah, so that concludes the talk. Any questions?
Thank you. That was a very nice and stimulating presentation.
Thanks. You all got it so right. So, gotta make it harder next time.
Thanks, Wes. That was great. I think
I
a couple
did
comments.
stick I put an article in the chat